Hello everyone. The White Army is very privileged today to have Dr. Rajgopal Shenoy from KMC Manipal University. Welcome you, sir. And we also have Priya Menon here, surgery second year resident from Agartala, and she's here to do a case presentation today. With your permission, sir, we can begin the session today.
Yeah, thank you. Thank you very much. I appreciate White Army. I'm audible?
Yes, sir.
Yes. So, Dr. Kishan and your entire team of Real Army, and I congratulate you for your achievements. And yes, Dr. Priya, you can start. You are a second year postgraduate. So, let us start from the presentation, and that as we take on, we'll see how we can go about it. Okay. All the best to
Yes.
you. You can start.
Thank you, sir. Good evening, everyone. Good evening, respected sir. I'm going to present a case on testicular tumor today. My patient is Mr. XYZ, a 31-year-old gentleman hailing from Kuwait, Tripura, who was a fruit seller by occupation and who was examined in our hospital on the 17th of August this year. He had presented with the chief complaint of swelling in the left side of the scrotum since 5 months. He was apparently well 5 months back when he first noticed the swelling in his left side of the scrotum. It was insidious in onset, initially around 4 into 3 centimeters and gradually progressed to the current size of around 6 into 8 centimeter. It was associated with a feeling of heaviness in the left side of the scrotum, not associated with change in size with respect to position or daily activities. There was no history of trauma to the scrotum, fever or pain over the swelling, and swelling in the right side of the scrotum. There was no history of mass felt in the abdomen or neck swelling, no history of lower limb swelling, no history of enlargement of the breast, or no history suggestive of distal metastasis. There was no history of previously known comorbidities or no history of scrotal complaints or undescended testis in the childhood. In the treatment history, there's no history of previous hospitalization or surgeries, or no history of any known allergies in the past. The patient has normal appetite, normal sleep, regular bowel and bladder habits, and no history of any addictions or consumption of recreational drugs. The patient is married, he has no children, his parents are alive and in good health, and there's no history of cancer or cancer related deaths in the family. Sir, shall I move on to my summary?
Yeah, please go ahead.
To summarize, this is a case of a 31-year-old gentleman with no previously known comorbidities, resident of rural Tripura, who had presented with complaints of swelling in the left hemiscrotum, noticed around 5 months ago, which was insidious in onset, gradually progressed from the size of around 4 into 3 centimeters to 6 into 8 centimeters, associated with heaviness, and there was no history suggestive of any distal metastasis.
Okay. Let us go back to your first slide. Yeah. Yes, correct. Yeah. Few things. Number one, I think this applies to everyone, those who are presenting. Always try to insert the slide numbers. Okay. Okay.
Yes,
the reason is very simple. In online, sometimes we need to go and ask, show slide number 8, slide number 6, like that. Okay. That is one thing you should
yes,
know. Instead of trying to, of course, this is a data, basically XYZ, etc. All of you will tell that. It's very simple. You can just make this sentences in the university examination. 31-year-old male, that's all. So who is interested to know the name at this juncture? Okay. So you can always tell 35-year-old male coming from dash place. Yes, occupation is important and presented to the hospital on that whatever date which you have mentioned. Okay. Right?
yes, sir.
Okay. So this is a first slide, a few comments. Now next. Yes. So there's nothing to. So this is a duration of 5 months. When somebody comes to the outpatient department, what are the things at this stage you will have it in mind? First question to you. This is the first slide. Yes, tell. Please go ahead.
So since he's noticed it for 5 months and scrotal swelling, I would think of epididymoarchitis in my diagnosis. Secondly, I would also like to consider, I mean, if there's a history of trauma, then I would consider hematocele in my diagnosis. And thirdly, considering the age group, I would also keep a differential of testicular tumor, probably of
Okay. All
malignant
right.
etiology.
So basically, what we have to understand is the testicular pain or the scrotal pain is absent. So that is one thing which characteristically you try to rule out the usually acute epidermolysis, etc. All right. So you have
Yes,
a
sir.
patient who has complained of young patient, 31-year-old, who has some swelling in the left side of the scrotum for 5 months duration. That's fine. So there is no other presenting complaints. Next slide, please. So here everything seems to be fine. One thing you all should know that I know very well what we are talking today. We know that we don't give much importance to this lemon and apple, etc. But what don't try to give a perfect 4 into 3, 8 into 6, 8.5 into 6.5, because you are, remember, facing the MS examination. So you should try to create an impression that you don't know the ultrasound findings. I know very well the limitations of this type of things. I personally feel you can always tell, sir, around you have already written there, small in size and gradually progress to current size. And if the
Okay, sir.
examiner will ask you, yes, figures, say lemon size or whatever it is, it amounts to 8 by 6. So with this complaint, 4 into 8 jump from 5 months. So this is typical of what condition? Does it happen in hydrocele? Next question to you.
No, sir. Hydrocele will be more gradually progressing, like even
So,
more slower than this, and it would be more long-standing.
so yes, hydrocele can be of a comparatively to go into 4 to 8 centimeter. So obviously twice an enlargement which has happened. So obviously we have to keep it in mind. We are alert now at this juncture, and he is feeling some kind of a heaviness. So what is this heaviness means?
So it
What
could
is
be the
yes?
dragging sensation because of the enlarged testicle.
No, 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 no. Dragging sensation is a different. Heaviness feeling. Obviously, some mass lesion is there. Okay. People
Yes,
with
sir.
the hydrocele, even
Yes,
if
sir.
they're very large size, they do not complain of heaviness. They will only complain of a swelling. So obviously, when the testis is enlarging, there will be some amount of stretching takes place, no? Capsule. So that's why that heaviness feeling. Why
Yes,
did
sir.
you mention about what is this not associated with the change in size with respect to position? What is that? What do you mean by that?
I was just trying to rule out if there's hernia, sir, because inguinal
The-
scrotal region.
So what you have to mention about that should be the last, not here.
Okay, sir.
First is patient complains of a swelling in the left side of the scrotum, 4 months duration, 5 months. In the last 5 months, it's almost double the size it has attained, and it is associated with the heaviness feeling, and at that juncture itself you should mention about what is that there is a no history of pain, fever, trauma, all that should come now, okay,
Yes, sir.
because you are confining yourself to only the scrotal lesion. You have never mentioned the hernias. Always hernia starts from above, correct,
Yes, sir.
and comes down. So, so you can mention this later, not also. Again, here change in respect of position, daily act. No. What you can tell is swelling is not related to any other irregular activities. That's enough. Position and all this is not required. Okay.
Yes, sir.
Why trauma?
So history of trauma would have resulted in a swelling. I just wanted to rule out if it is hematocele, sir.
Correct.
But
It is
it's
it is not uncommon testicular trauma and causing a bleeding there. So what about why fever and pain?
so with respect to epididymoarchitis, but that would be more acute in presentation. In this case, if there was a history previously suggestive of chronic epididymoarchitis, I wanted to rule out that.
Like what history?
So recurrent onset of pain over the scrotum associated with
Yes.
fever.
Correct.
Then,
What are the common conditions for that? Chronic epidermolysis.
so TB epididymoarthritis could be chronic, or
Yes.
previously unresolved acute onset also could result in a chronic condition.
Yeah.
Syphilitic is rare.
Yeah. But the other common condition probably you may not see in your place where you are presenting. Coastal is a filarial epidermolysis. It's quite common. You heard of that? Filarial?
No, sir.
No. No.
I mean, in the
Epidermal.
textbook I've read, sir. I've not seen any
Okay,
patients
no
with that.
problem. Filariasis and filarial epidermolysis is one of the common conditions apart from the tuberculous epidermolysis, filarial epidermolysis, of course, sexually transmitted diseases. So, epidermolysis itself is a huge, huge question to you people. So, fever with the chills and rigors is classical of a filarial.
Yes, sir.
So, you are telling there's no history of pain and a fever over the swelling. And anything else at this stage related to the swelling, etc.? Why did you mention swelling in the right side of the scrotum? Suddenly.
I mean, it was to rule out if there's also a tumor on the right side. So, I mean, history, whether he had noticed it before,
No.
and then he's
This,
noticed it now on the left side.
yeah. So what I want you to understand is first you complete the whatever you suspected malignancy. So it is on the whatever left side. So you say that no other swellings elsewhere he has noticed. Example, maybe abdomen, maybe supraclavicular region, neck, etc. Okay,
Yes, sir.
right? Then you mention about no all those right side, etc.
Yes, sir.
Okay, proceed. Next. Yeah, I think you have written there. Why lower limb swelling?
Keeping the differential of testicular malignancy in mind, sir, if it is involved the lymph nodes of the retroperitoneal region, then that compresses onto the IVC, then there could be venous stasis causing lower limb swelling, or if the
Mm,
lymphatics are involved. It was considering that I've taken this history.
no. Just 1 minute, 1 minute. I know that. Okay, can you just quickly give me some differential diagnosis of unilateral limb swelling, painless,
Yes, sir.
unilateral. First is unilateral.
So filariasis can have a painless
Okay,
swelling.
it starts with the
Unilaterally.
lymphangitis, very painful condition, lymphangitis, redness. Later, of course, chronic, it becomes okay. Next, and what I wanted is, yes, come on. Any other swellings? Unilateral.
Not sure.
Unilateral limb swelling. One important thing is a deepened thrombosis. So, why venous thrombosis? Hello?
Yes, sir.
Yes. So, you were talking about the lymphatic obstruction. It's not uncommon to get a venous thrombosis. Malignancies, you heard of Virchow's triad?
Yes, sir.
What is that?
So in Virchow's triad, there will be endothelial dysfunction, venous stasis, and
Endothelial damage and, of course, hypercoagulation. Okay.
hypercoagulability, sir.
So malignancies are known for the venous thrombosis. So, you have mentioned about the retroperitoneal nodes, retroperitoneal nodes to cause a venous thrombosis, IVC obstruction. It takes significant time. So,
Yes, sir.
limb swelling is, you got to understand the malignancy and venous thrombosis mechanism here. Okay.
Yes, sir.
Right? Okay. Yeah, yes. Enlargement of the breast. Why is that?
So that was to rule out if malignant testicular tumors, sometimes they can produce hormones, so which could have resulted in enlargement if they're a functional tumor. So I just wanted to rule that out.
That is so patient does not complain of any. So no history suggestive of a distant metastasis. So it is better not at this juncture to think that it is malignancy and go on mentioning no history suggestive of metastasis. Okay.
Okay, sir.
It is like before a lady with coming with a breast lump, you take it for granted that it is carcinoma and asking for no history of uh, headache, coma, convulsions. It's not required at this juncture.
Yes, sir.
Once you say that testicular enlargement is there, it's a sequential abdominal distension and Systemic one symptom, it's enough. No history of cough is enough. So that indirectly to tell a permanent metastasis. Okay.
Yes, sir.
Because how does the distant metastasis in the brain present as?
So they can have, features of raised intracranial pressure, headache,
So
or they
correct.
can have giddiness, blurring of vision.
So non-seminomatous tumors sometimes, you know, with the elevated hormone levels, they can even have a cerebral metastasis.
Yes, sir.
Okay, that becomes one of the indications later. Of course, I would ask you later this question for an MRI of the brain. Okay,
Yes, sir.
not in the initial evaluation. Okay. Uh, any other things from your side here? So you asked for the local related problem. That is so you ruled out a trauma. You ruled out
Yes, sir.
sexually transmitted diseases and uh, testicular painless enlargement, complaints of heaviness. We know very often we are dealing with the testicular tumors, but expect examiners definitely will ask you epidermolysis, filarial, syphilitic. In the syphilitic epidermolysis, what organ is involved more, epidermis or testis?
The epididymis, sir.
Syphilis does not affect much of the epidermis. Syphilis affect the testis.
Yes.
Okay.
Okay, sir.
And tuberculosis, interesting. Tuberculosis, more effects, more effects.
So not
Epidermis.
sure epididymis.
Epididymis. It does not affect the testis. Okay. It does not affect much of a testis, even though it's called as tubercular epididymoarthritis. Okay.
Yes.
It's interesting. Each disease has a certain reasons and explanations. So we'll come to that a little later in the differential diagnosis. When you ask, I'll ask you that question again. Yeah, please go ahead. Go ahead. No. In the past history, I think, where is that? Yeah, one. So, no history of any scrotal compare more than anything procedure. Okay, you are written there. You are written there. Okay.
Yes, sir.
Surgical procedure. That's important. You are written no history of a hospitalization surgery. What surgery?
So I was trying to look out for orchidectomy, sir, again specific to undescended testis.
Why?
So if the patient, even though if the patient has undergone orchidopexy, there's still around 2 to 3% chance that that might develop into a malignancy later on.
Okay.
So
So because we don't want any scrotal incisions.
yes.
That is the main reason. Okay. You know the treatment when it comes the orchidectomy part of it. Okay, please go ahead. Yeah, I think there's nothing much to talk about this in relation to the testicle tube. Please go ahead next. Yeah, anything particular here? Any syndromes, here? Any syndromes? You heard of any Klinefelter syndrome,
Klinefelters
etc.?
with respect to testicular tumors, yes, sir.
Good. Next. Why it's important that married, go back that slide, this has no children. Why this statement is important in your case?
So later on, if the patient gets diagnosed with testicular carcinoma and then we're going to operate, then in that case, sperm banking becomes
Good.
an aspect, sir. So that is why.
Yeah, it's important here. So he has no children. The another one of the rare presentations of the testicular tumors is also called a hemospermia. Okay.
Yes, sir.
Hemospermia. Okay, please go ahead.
Summary, sir.
So at this juncture, if they ask you what is the diagnosis, what will you tell?
So considering the age of the patient, then secondly, based on the progression of the symptoms, I would consider testicular tumor of malignant etiology, sir.
You just say testicular tumor. Okay.
Okay.
So we know that 99% 31-year-old male coming with it is a malignancy unless proved otherwise. Okay.
Yes,
So
sir.
benign tumors are very rare. So we'll put it like, sir, I would like to consider malignancy as my first possibility in this patient. Examiner will ask you, do you think it's epidermolysis? What is your answer?
At this juncture, no, sir. I don't think
Do
it's
you, do, do you
epidemiology.
think it's hematocele?
No.
So in the absence of, trauma, can somebody have a trivial trauma and hematocele other than malignancy? Do you know any other disease without a trauma can bleed? Yes.
Sir, no.
Bleeding tendencies. Bleeding
Yes, sir. With
tendencies.
coagulopathies, they can have.
See, this is how the examiner will take you in a different directions.
Yes, sir.
Okay. So it is like that. So spontaneous hematomas. So you keep it in mind, spontaneous hematoma, traumatic hematoma, and even a secondary hydrocele of malignancy, sometimes transformation will be obviously negative and it will be sometimes blood also. Okay. So
Yes,
just
sir.
to keep it in mind.
Okay, sir.
Yes. Yes, proceed. So obviously we are ruled out hernia because at this stage they will ask you comments. Inguinal scrotal swelling is hernia. So in this patient, there's no inguinal element here. It's only the scrotum. Patient is very clear about it. So I would not like to consider a
Differential of
consider this
hernia.
case. Okay, all right. Please go ahead.
The general survey of examination, patient was examined after taking informed consent in a well-lit room with adequate exposure. It was done with the patient in both standing and supine position. Patient was conscious, oriented to time, place, and person with a Karnofsky score of 90. His weight was 58 kg and height was 1.67 meters, amounting to a BMI of 20.79 kg per meter square. His vitals were as follows. Temperature was 98.5 Fahrenheit. Blood pressure was 110 by 70 millimeters of mercury, recorded in the right arm in supine position. Pulse rate was 80 beats per minute in the radial artery and it was regular. And respiratory rate was 15 cycles per minute. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Uh,
Just go back to that because otherwise I'll forget. General physical exam. Why did you? There's nothing wrong in telling survey the word. Let it be a proper word, general physical examination. Okay? You know,
okay, sir.
you understand what I'm telling. Okay.
Yes, sir. Yes, sir.
No doubt we survey, no doubt, from starting from the head to toe that has been mentioned in the books. It's a simple word, general physical examination. Yes, it is understood that we take a consent, that is fine, nothing wrong in that. Uh, unless and until specific, you don't have to write patient here in the standing position, supine position at this juncture. Okay?
Okay, sir.
You just do a general physical examination. I have examined him, whatever conscious, all that you have written, that is fine. I am nothing against all that thing. Obviously, you do it. When its specific issues come, you make the patient standing for a general physical examination. Can you tell me
Yes, sir.
when do you make the patient standing? Since you are written there, examiners will definitely ask you this question.
So, inguinal scrotal reasons we prefer the patient,
Just a
to
minute,
examine the patient in standing position.
just a minute. If you have a case of a hydrocele, standing position is better, is it? Hydrocele. Hydrocele. You know hydrocele, you have to do a translumination
Yes,
test,
sir. In that.
reducibility, you have to rule
Yes,
out. So that is one. Okay, you want to basically rule out hernia, correct?
yes, sir.
My question to you is giving a little more thought process for you.
Yes,
When
sir.
do you make the patient stand to look for any veins? Any
Varicose
veins?
veins.
Veins, varicosity, correct.
Varicosity, okay. Yes,
And
sir.
and to look for the direction of the flow, especially abdominal wall veins.
Yes, sir.
Okay, abdominal wall veins. You heard of that?
Yes, sir.
Direction of the flow for a lateral veins of IVC obstruction and central veins in a
Yes, sir.
portal hypertension. Okay, so examiner will ask you. So just a simple things. So patient is all the consent, that is fine. General physical examination. Yes, I look. You are written there, conscious, oriented, or all that thing. And Karnofsky score is 90. You are written. At this juncture, examiner will ask you at least retrospective, since you are given the diagnosis, knows that it's a testicular tumor, whatever you are given, which score is better at this stage? You heard of ECOG
ECOG would
score?
be better, sir.
Which one?
ECOG would be better, sir, if you're considering the diagnosis of malignancy
Why?
instead of
Why?
carnoscopy.
Why?
So that's specific to cancer. So
Anything else? Yeah, reasons, particularly, why it came up in a big way. The reason is because Kanofsky is fitness basically. ECOG started with a, abbreviation of that. ECOG. It's a Eastern Cooperative Oncology Group. Okay.
yes, sir.
Because a patient with a malignancy will not just receive nowadays only surgery. What else he will receive?
There's options of chemo,
So
radiation.
many are there. So
Yes, sir.
not only chemotherapy, radiation, immunotherapy, so many treatment. So you should be fit,
Yes, sir.
not just for surgery. Okay. So that's why. Yes. Please go ahead. Next. Okay. Here you have written there. Everything is fine. So otherwise, vitals, pylorictus, all cyanosis, clubbing, all that you people write. But I wish you will add always a spine tenderness. Okay.
So
In
I've
the
added that in the ending, sir. Examination of the spine.
examination of the spine. Okay. Or not examination of the skeletal system. That's what you mean? Or
It's in spine as a separate word I mentioned, sir, considering the case. I mean,
okay, no problem. Go ahead.
so on inspection, the left inguinal region, there was an 8 into 6 centimeter swelling in the left hemiscrotum, extending up to the root of the left hemiscrotum. The midline of the scrotum and penis was deviated to the right, and the rugosity over the scrotal skin appears normal. The right inguinal region appears normal.
Go to the next. Yes.
On palpation, the left heavy scrotum, there was no local rise in temperature over the swelling. 8 into 6 centimeter size swelling, which is hard in consistency, globular in shape, not fixed to the overlying skin. It was possible to get above the swelling, and cord structures were palpated at the root of the scrotum. Testicular sensation was not looked for, and there's no local lymphadenopathy. There was no local lymphadenopathy. And right hemiscrotum was normal, hernial orifices were normal, and the penis was also normal. Should I
Yeah,
proceed,
just
sir?
nothing very. So at this juncture, you have written that the inspection findings, and that's fine. Let us not go to this picture because sometimes they will ban this. You have shown this picture, so go to the next immediately. What's important here is that uh, apart from the testicular swelling, whatever you have mentioned about size, shape, that has to go in the same fashion. I'll appreciate if you were to mention one word there, no expansor impulsion cough. Okay?
Yes, sir.
It's important because why it's important? Because you started telling examination of the inguinoscrotal region, correct?
Yes, sir.
Even though in
It
this
was
patient it is
specific to
we
scrotal
start with
region.
first scrotal region.
Yes,
Then
sir.
we go. When we go and find out there is no expansor impulsion cough.
Yes, sir.
Because undescended testis and even the can have various complications, including a hernia. Correct?
Yes,
So,
sir.
so that is one thing you should mention. There it requires the standing position to rule out a expansor impulsion cough.
Yes, sir.
Palpation wise, one important thing nicely you have written there, that's fine, hard. Yes, globular you have written. So other features of testicular malignancy include one is hardness, second is you have
Um,
written
it's not.
globular.
Yes, sir.
So usually what happens sometimes the testicular shape is lost, some irregularity, hardness, and tenderness. Testicular sensation, of course, you have written there, no problem. Written there, not testis. What is this testicular sensation? You are not done, it doesn't matter. What is it?
So, as
What
in,
is
usually, the one of the early features of malignancy would be that the patient would say that the sensation is lost. So, if I have to palpate that, then I would.
no problem. I'm not trying to say that don't it's not worth doing it. That's a different issue. Today you have the imaging everything.
Yes,
But
sir.
for a theoretical, what exactly the feel of the patient when you do the testicular sensation means what? It's a sickening feeling. Okay.
Yes, sir.
It's a sickening feeling. You have written there, cord structures are palpated at the root of the scrotum. What exactly you mean by sign of VAS? This one question they may ask you. Sign of VAS.
Sir, I'm
What
not
it
sure.
Okay, no problem. What it means to say is in epididymo-orchitis, cord will be very tender, cord can be thickened. There's another disease which is common since you mentioned tuberculosis epididymo-orchitis. What will be the nature of epididymis in tuberculosis and the vast difference in tuberculosis?
There would be beaded, sir.
Very good. Beaded vas and craggy epididymis. Craggy means craggy, some kind of a rough surface, irregular.
Yes, sir.
So one of the DD, when the epidermorchitis and testis involved, is this sign of vas means when the vas deferens is affected, it is not a testicular tumor. Is it clear to you?
Yes, sir.
Is it clear?
Yes, sir.
So what it means is the other way. In testicular tumors, it's very unusual to get the spermatic cord involvement. Irregularity, induration, bleeding, all the tenderness, even though there can be sometimes cremasteric hypertrophy. Okay?
Yes, sir.
But so that's a very important point which is here. Possible to get above the swelling and cord structures palpated at the root of the scrotum. Normal, you should write.
Yes, sir.
Not cord structures are palpated always at the root of the scrotum.
It's normal. That should
Nothing
Yes,
unusual
sir.
about it. So what is important here is cord is not thickened, not
Yes, sir.
involved. That's the time they ask you the question. What is sign of VAS? What do you understand by that word, possible to get above the swelling? It means?
It is a scrotal swelling. The origin
Very
of the
good.
swelling is from the scrotum.
So that means we'll put it this way. It is not an inguinal-scrotal swelling.
Yes, sir.
Okay. So it's a pure scrotal swelling like hydrocele, testicular tumors, etc. Where you will be able to get above the swelling. Correct?
Yes, sir.
Yes. Any secondary hydrocele? That is what I wanted to ask you this question here. Yes, consistency is hard, you are written, then it's over. Okay, there are no soft areas. So if you get a soft area, what do you suspect in a testicular tumors?
So one is that if it's variable in consistency with soft area, could be a teratoma, or that could be a secondary hydrocele over there. So that would result in
So
soft
if there's
consistency.
a testicular secondary hydrocele, that's what I was talking to you some time back, that they are all the transformation will be negative. So
Yes,
at this if there's a fluid there, okay. So like you have a testicular tumor, filariasis, all these conditions, chylocele, pyocele, you will have a transformation is negative. So you look for the testis, you look for the spermatic cord, but you are not mentioned about epididymis. So where do you feel it? Anterior or posterior?
so posteriorly.
So you have to. Why it's important? India, I mentioned to you, tuberculosis epidermorchitis. The manifestations beaded vas and thickened, craggy, irregular epididymis which you feel behind the testis. Okay.
Yes, sir.
And what happens later if there's a tuberculosis? Like neck, you get a lymph nodes, then it goes for what? Next stage of neck?
Cold abscess, sir.
Very good. So what happens when it ruptures in the scrotum?
Would form a
Yes.
sinus that would.
Where? Correct. Obviously, posterior sinus. Okay.
Yes, sir.
Posterior sinus. Okay. Right. So there are some more questions on this. This you can read about it. Okay.
Yes,
When do you get anterior sinus? When do you get posterior sinus? Okay. Right. So that's about. So you have to mention about the testis. You have to mention about the spermatic cord. You have to mention about the epidermis. Do you expect the skin involvement in testicular tumors? Next question.
not unless it's an advanced stage, sir. Not very common.
So yes, theoretically anything is possible. What we are trying to tell is it is nothing like never involved in, but it's very very rare. That's why we always tell you don't inside the skin
Yes, sir.
because That will come to the treatment. So left side is over, right side is over. Hernia orifice, you have written normal there. Penis normal, yes, correct, but you should have mentioned the circumcision done or not done. Okay, circumcised. Okay,
Yes, sir.
okay. And anything else? Next.
So per abdomen findings were soft, non-tender, there's no organomegaly.
What did you look for? Organomegaly means?
So particularly with respect to the liver, and I was ruling out if there's any lymph nodes, which would be palpated in the epigastric region.
Very good. Why not inguinal nodes? Why not iliac nodes?
So the testis doesn't drain into that. If inguinal nodes are involved, that means the drainage is happening from the scrotum, and if that is the case, it would suggest metastasis.
Of course, we have mentioned unless it is incised.
Yes, sir.
Somebody does a blind, biopsies or a blunder of incising the scrotum for a testicular tumor. So that is one of the important things you should keep it in mind. So your answer should be abdomen. I look for actually the parietic nodes, basically the epigastrium, etc. Okay, you have written there no enlargement of the neck nodes, spine normal, only spine you have written, no other skeletal system. So it's important, okay, to
Yes, sir.
mention about skeletal system. Anything else in particular? Lymph nodes you have mentioned, testis you have mentioned, and examination. Okay, come to the diagnosis.
So this was the summary with the examination part, sir.
Okay, I think let us not repeat whatever
sir.
has been told. That's okay. Please remember in the university exam, long case sheet.
Yes, sir.
We don't expect you to write the summary at every stage. Okay, that is of course you have to find out from your internals because this has come up only after the COVID time. When you are doing online presentations, examiners wanted you to quickly summarize so that we know, recollecting. Okay.
Yes, sir.
So, okay, left-sided testicular tumor, most probably malignant. Yes, fine.
With no
no
evidence of
evidence.
distant metastasis.
So at this stage, you can probably clinically at least, yes, we know that when you give a diagnosis of malignancies, if possible, do a clinical staging. We all know very well that at the end it's a pathological staging.
Yes, sir.
So what do you think clinically at this juncture?
So it will be T1 M0
It is
N0
stage
M.
1 only, correct?
Yes, sir. Stage
Stage
1.
1.
Yes, sir.
Suppose this patient has got a, let us say, palpable nodular liver, what stage it becomes?
So then in that case, it would become stage 3.
Very good. Not stage 4.
No, there are only 3 stages.
Oh, excellent. That is why I wanted to ask you that question.
Yes.
So there's no stage 4 in testicular tumors. There are some more things. So basically, your diagnosis should be testicular tumor. Yes, most probably malignancy. Why malignancy? Answer you already mentioned. Just to repeat.
So considering the age, then the consistency of the swelling, I mean, from history, considering the age of the patient, and secondly, the incidence and onset and progression of the disease, then from the examination findings, the size and the consistency, it was hard inconsistencies also.
It's basically you are ruled out. We are ruled out a hematoma, we are ruled out epidermolysis, we are ruled out. That's what is important for a differential diagnosis.
Yes.
Okay, just one or two questions. We know it's malignancy, no doubt about it. Just give me 1 or 2 DD for a hard testis. One is malignancy. Hard testis.
So chronic epididymoarthritis can have hard testis.
Say hematocele, organized blood. Anything else? So in syphilitic, I asked you some time back, syphilitic epidermolysis.
Yes, sir.
It's more than epidermis, testis is involved. In fact, it's called a billiard ball testis. Okay. So heart, yes, organized hematoma, chronic diseases, all these are producing a heart testis. Okay. Sometimes, tensely cystic spermatocele, tensely cystic.
Yes, sir.
Sometimes I feel a hard clinical. Okay. Yes, we can. So that's your diagnosis. If they ask you
Yes, sir.
clinical diagnosis, yes, it is a stage 1 disease. So tumor is there, nodes, and there's no clinical metastasis. Okay, then how do you proceed?
So in my patient, I would like to firstly do an ultrasound of the bilateral scrotal region, sir. Ultrasound of the scrotum, bilateral testis, and I'd also like to go ahead with serum markers, sir. That is AFP, beta HCG, and LDH.
What do you expect ultrasound findings in your patient?
So like it will confirm the origin of the swelling, sir. That in this case it will be from the testis. Secondly, the consistency and the size.
Slow. Don't say consistency, size. You're fairly accurate, 6 by 8 and all that. Consistency for which we don't use ultrasound. Okay, you're doing ultrasound for few things like what is the ecogenicity of this? That's
So
what they ask.
echogenicity is what I meant, sir.
Uh,
Sorry.
Hypoechoic, correct?
Yes,
And
sir.
some heterogeneous, and most importantly, tumors are vascular.
Yes,
Okay,
sir.
so that's why you can even add a Doppler. Okay, whenever
Yes,
you
sir.
have a vascularity, for example, you want to check for a testicular torsion, you also not just mention ultrasound, you also mention a Doppler, correct?
Doppler. Yes, sir.
So that is the first baseline investigation you do. Okay, you have examined the patient, you have set the patient to the ultrasound room. At that stage itself, you finish the ultrasound of the abdomen. Okay?
Yes, sir.
Anyway, you are doing the ultrasound. Ultrasound is extended clinical exam. It may tell even a parietic nodes. So you know very well it can pick up. So okay, ultrasound has said suspicious of a testicular tumor. What is your next investigation?
Sir, I'd like to go ahead with the CECT of the whole abdomen and pelvis.
You mentioned about the tumor, some markers or
Markers, sir.
something.
Yes, sir.
Like what are those?
So beta
Basically,
HCG, LDH, and alpha fetoprotein.
just quickly, what is in what condition is alpha fetoprotein is increased?
So yolk sac tumors, alpha fet would be more specific towards alpha fetoprotein, sir.
So
Uh,
basically, we have a hormones means you have to think of germ cells, correct?
yes, sir.
Like examples of that are choriocarcinoma,
Yes, sir.
Yes. So embryonal carcinoma. So they are all the yolk sac. So what is the importance of elevated LDH?
So
Can you
that,
hear me?
yes, sir.
Yes.
So for non-seminomatous germ cell tumors, LDH can be elevated, sir.
What I wanted you to understand is LDH indicates a tumor activity burden. Okay.
Yes, sir.
So it may not decide. Okay. It's important in a we have to follow up these patients, correct?
Yes, sir.
Curable disease. So we start with alpha fetoprotein. Yes.
Yes, sir.
Then beta HCG.
And
Okay.
then LDH. Yes,
And
sir.
okay, you are done it. And patient comes and comes with the everything is normal. Metastatic workup. So once you make a diagnosis suspicious of a malignancy, you do a your answer in the exam is after ultrasound is suspected, examiner tempt you and ask you, do you do a biopsy before
No.
doing a metastatic workup? Your answer should be all suspicious lesions of testicular tumors. I will not do a biopsy through the scrotum, whatever it's FNAC, nothing. Okay.
Yes, sir.
So then, yes, you have done the CT scan, abdomen, pelvis, so normal. CT, chest, abdomen, normal. Then what do you do?
So then, I mean, in addition to this chest X-ray, also I would like to do
Everything is
a
normal.
part of the. Then I'd like to proceed with high inguinal orchidectomy, sir. Left-sided high inguinal orchidectomy for my patient.
Yes, we know that we are suspecting malignancy in this patient. You have no doubt because dictum is 99% it is malignancy. So it's important that other testis is normal. We assume. Okay. in your patient who has no children. So you already mentioned about the sperm banking, etc.
Yes, sir.
So high degree of index of suspicious. Yes. What are the components of that? Please use the word radical, high, inguinal, orchidectomy.
Yes,
What
sir.
is the what do you mean by that word radical here?
So we're removing the testes with the mass, including the spermatic cords, sir, all the way up to the deep ring.
Very good. So you earlier there used to be a procedure they wish to mention it, Schwartz's maneuver. Okay. You have any idea about that?
No, sir.
No doubt, inguinal incision only. You make an inguinal incision and deliver the testis there. Before that, you are going to handle the testis, correct?
Yes, sir.
So to prevent the tumor embolization, they used to put soft clamp at the
Spermatic cord.
testicular vessels, especially to avoid the tumor embolization.
Yes, sir.
And do a small biopsy, wait for frozen section, and then if it comes as benign, close, because these are days of before the scanning, etc. So components of a high inguinal orchidectomy includes, yes, you have mentioned, testis,
Yes, sir.
cord structures, and all that need to be removed. Yes. Let us say the report comes as, then you have to tell what will you do, wait for the examiner. Sir, I would like to know the histopathological report. Say report
Yes, sir.
comes as seminoma, what will you do?
So seminoma, and if it's stage 1, sir, then in that case, I'd like to put the patient on surveillance.
Yes. What is the components of that?
Sir, I mean, we'll be following up the one thing is that, sir, post-OT, I'd like to follow up on the patient's tumor marker levels, sir. Secondly, also repeat a USG, sir, of the scrotum.
Okay. Just to add you some more, since you are a postgraduate, your report has come seminoma, but there are increased levels of alpha fetoprotein. You understood the question?
Yes, sir.
So it's not common to get a increased alpha fetoproteins in seminoma. Okay.
Yes, sir.
So what does it tell you then? Basically, it tells it's a mixed germ cell
Of the
tumor.
tumor. Yes, sir.
So whenever you find the high tumor markers, in addition to the high orchidectomy, what is to be done for the patient?
Go ahead with chemotherapy, sir.
Yes, very good. Reason is? Yes, reason is simple. Tumor markers, high tumor markers indicate there is a systemic spread
Yes, sir.
of the disease. So the reason why you give the systemic chemotherapy.
Yes, sir.
Okay. So one or two other questions to you. What will you do? When do you do the retroperitoneal lymph node dissection? We'll move on from stage 1. She said high orchidectomy, fine. If the tumor markers are high, you add chemotherapy. So, and in case if from the stage 1 we have moved to stage 2, of course there are many other things here in oncology. There is a lymphovascular invasion, grade of the tumor. There are so many things are there. So, but otherwise, orchidectomy followed by surveillance. You answered perfect. Now, suspicion of a lymph nodal metastasis or prophylactic. When do you do the retroperitoneal lymph node dissection?
So in a patient with seminoma, if they're presenting with stage 2A, 2B, then I'd like to go for retroperitoneal lymph node dissection.
Ideally, it is in a non-seminomatous, no?
Yes, non-seminomatous tumors also will go for
basically in stage 2, A and B. So you have to go for a retroperitoneal lymph node dissection, correct?
Yes, sir.
So do you know any component of that? Do you know RPLND?
So we
Yes.
excising the lymph nodes from lymph nodes surrounding the renal vessels to the IVC and then the paraaortic lymph nodes, sir, including the lymphatic tissue as well.
Yeah, just like, the testicular vessels, they pass the deep ring, no, side of
Yes,
that
sir.
till so up to the, right side up to the vena cava, left side up to the renal vein, the entire thing has to be cleared. Basically, you have to spare the nerves. The what are the usual problems of that retroperitoneal lymph node dissection? Do you know any problems
So
are
if we injure the sympathetic nerves, then that would be a problem, sir. And then secondly, they can also land up with post-surgery tachycardia for a period of 3 to 6 months.
what I'm trying to tell is basically injuries.
Yes, sir.
Injuries.
And sir, retrograde ejaculation can be a problem, sir.
Basically, you would like to know the vascular. As a postgraduate, you should know the vessels in the
Yes.
retroperitoneum, lymph, lymphatic ooze, vessels, bowel, ureter. You know,
Yes, sir.
all these are important. In addition, there's a retrograde ejaculation. So erection is not the problem. So these have to be mentioned, talk to the patient, especially RPLND, when it is done. Okay.
Yes, sir.
Yes. There are a few more things here. Always remember, when in doubt, you do inguinal exploration, send for frozen section, and patient who has only one testis, or if you want to save the testis, early cases, there is also, from your point of view, if they ask you only answer this question, that is what is called as now partial also. Like everywhere you conserve, no?
Yes, sir.
Penis also, penis, breasts, everywhere. That has to be mentioned not as a first line of treatment, only when the examiner asks.
Okay, sir.
Otherwise, high orchidectomy. Okay. Lymph nodes, retroperitoneal, block dissection. Okay.
Yes, sir.
Yes. And the complications of retroperitoneal lymph node
Lymph node
dissection.
dissection. Yes, sir.
Okay. Yes. Then the common last questions for you is staging, stage 1, stage 2, stage 3. They will also ask you suffix. Yes. Yes refers to, tumor
Clear
markers.
markers. Yes,
Yes.
sir.
Correct. Yes. You have to consider LDH, HCG, and alpha fetoproteins.
Yes, sir.
There's only stage 3 are there, not a stage 4.
Yes, sir.
Yes. Then what about role for radiation?
So if it's seminoma, if it's a seminoma, then that is radiosensitive. So then we can consider radiotherapy as well.
Yes. So, there's something they used to tell, like a melt, melt like a snow. That's what used to tell, no? It
Yes, sir.
responds very well. Some of the histological types and clinical type. One of the dangerous variety is used to be hurricane variety of seminoma, which used to be get confused with the epidermolysis. Okay,
Yes, sir.
that's where the blunders used to take place, where they used to incise to the scrotum. So that is one of the. So we have to always look into the pathology.
Yes,
Okay,
sir.
pathology. That's very important, and tumor markers are extremely useful. Okay, what about PET scan? So
So
you
PET scan will have a role like post, I mean, in with respect to non-seminomatous tumors or post chemotherapy, we can use PET scan for follow-up, sir.
yes. So there is no initial evaluation. We don't use it. So stage 1, in a quick summary, stage 1, you would confine yourself only to the local regional control of the testis there. Stage 2, of course, the lymph nodes. Again, here comes the role of tumor markers, high
Yes, sir.
tumor burden, chemotherapy, and even radiation.
Yes,
Okay.
sir.
And chemotherapeutic drugs. There are so many drugs available. Then some immunotherapy is also available. So few things like sperm banking you already mentioned. And then seminoma confined only to the testis. You have done a orchidectomy. If patient wishes to have a testis, you should mention what?
Partial
No,
orchidectomy.
no. Okay, sorry. Reframe my question. That is, as I mentioned to you last, what I'm telling is prosthesis. Okay,
Oh, yes, sir.
prosthesis. So that's from PG level. You also should know about
Yes,
that.
sir.
So it's available. These things are also being done. Okay. So in case if this patient were to have a bilateral disease, that's what I'm trying to ask. Bilateral. Then comes the problems of the testosterone. Okay.
Yes, sir.
Bilateral orchidectomy. So apart from this, seminoma, then comes the non-seminomatous tumors. So elderly people, what other tumor can happen in the, not in your case now, they just moved out. Elderly people, testis is one of the sites of what? Any other tumors? Apart from the Leydig cell and Sartori cell, etc.
So lymphoma.
Ah, yes. That is another disease you should know. Okay.
Yes, sir.
So I think I will stop at this juncture. First, one or two questions from Dr. Priya. You want to ask any questions related to theoretical aspects? You can always read. You have a lot of resources available now in your mobile only. You have the artificial intelligence, not intelligent, artificial intelligence. So you can get the staging, you can get the recent recommendations, etc. At a postgraduate level, you please go through the NCCN guidelines. Hundreds of pages are written there.
Yes, sir.
NCCN, recommendations.
Yes,
So
sir.
in which they mention lots about this invasion of the epidermis, and then comes the lymphovascular invasion. So many things are there. Okay.
Yes, sir.
So, any questions from your side?
No, sir.
No. Oh, perfect. Okay. What about others? I don't think many students have logged in, no? Okay. You have done a good presentation. You have read well. Okay. Fine.
Thank you, sir.
So, this is an opportunity for you to quickly now do the revision of the testicular tumors, staging, then lymph nodes. There are many criteria: lymph node size more than 3 centimeter, less than 3 centimeter, numbers below the diaphragm, above the diaphragm. That's
Yes, sir.
so much you can read about it. Okay,
Yes,
right.
sir.
Okay, good presentation. Best wishes to you. Okay,
Thank you, sir.
right. Okay, organizers, White Army.
Thank you so much, sir. Is it
Okay.
done?
From my side, it is done. I asked her any doubts or questions. She has no doubts. She is very clear about that. So,
Okay.
but one thing, please develop the art of clinical examination. Okay.
Yes, sir.
That's important because in a given patient, you should know when somebody comes with a testicular swelling, no doubt we do consider rapid growing mean testicular malignancy. Quick survey, what you have written should be converted into quick general examination. In that, it's mentioned as head to toe, no doubt, but it's important. You have to quickly should be able to put your hand there, supraclavicular to check, then epigastrium, then of course the testis. Already you have mentioned very well there. Testicular pain, tenderness, pain will be lost, in testicular tumors, hard irregularity. In India, tuberculous epidermolysis. Uh, you need to know parts of the epidermis, what is head, what is major, what is minor, where does the tuberculosis affects. So little more epidermolysis is an area you are weak. Tumor
Yes, sir.
you are read well, but we all know examiners when they come to you, they know that you probably know the diagnosis. Somebody would have told you what case is there in the world. So they would like to ask you questions also related to the case, but not about the case. This you should know.
Yes, sir.
You have an epigastric mass, you know it's a carcinoma stomach, but they may ask you on carcinoma pancreas. Just to get a broader idea. So prepare yourself well. All the
Yes,
best.
sir.
Okay,
Thank you,
thank
sir.
you from my side.
Thank you, sir.
Thank you so much, sir, for giving your valuable time to us and to the White Army team. The session was really useful to us, and we would request your support throughout the journey. And also, thank you so much, Priya, for being there with us. Thank you.
Convey my special congratulations to Dr. Kishan. Okay.
Sure, sir.
Okay. I met his one student just yesterday in Chitradurga,
Okay, sir.
postgraduate. She has presented a case some time back to me earlier. Okay. Thank you.